Hello, everyone. I'm Juliana, and I'll be presenting the anesthetic considerations for multiple sclerosis. This is part of the neuroanesthesia rounds. In terms of my objectives, I would like to discuss the definition, prevalence, and symptoms of multiple sclerosis. I would also like to go through a diagnostic criteria and disease progression, and then we'll talk about the latest treatment guidelines in the management of MS. Lastly, I will spend some time talking about the anesthetic considerations in the management of patients with multiple sclerosis. So MS is an autoimmune disorder. It is characterized by the demyelination of the spinal cord and brain. This myelin disruption leads to impaired neural transmission, which gives rise to the characteristic symptoms of this disease. The etiology remains unclear at this time. It has been suggested that there's an interplay between genetics and environmental factors in the development of this disease. More specifically, it has been suggested that an antigen-presenting dendritic cell crosses the blood-brain barrier. It converts some T cells into inflammatory cells, and these cells then induce macrophages to produce cytokines and oxygen radicals, which will then lead to the demyelination and axonal decay characteristic of multiple sclerosis. In terms of the prevalence, MS is known as the most frequently occurring demyelinating neuromuscular disorder. Its prevalence seems to increase with latitude, and the highest numbers are seen in North Scotland, Northern Europe, United States, and Canada, with the lowest prevalence being seen in Asia and India. In terms of the symptoms, it all depends on the site of demyelination. So for those patients with most of the demyelination occurring in the brainstem, they will exhibit nystagmus, diplopia, ataxia, autonomic dysfunction, and respiratory failure. With those exhibiting most of the disease at the level of the spinal cord, they will have symptoms including weakness in paresthesias. Most of this weakness affects the legs more than the arms. They can also have bowel retention and urinary incontinence, central neuropathic pain, trigeminal neuralgia, spasticity, and in some cases, they can have tonic-clonic seizures. In this slide, I just want to point out the wide spectrum of symptoms that we can see in multiple sclerosis. And this highlights the difficulty of diagnosing multiple sclerosis. Most of its symptoms are not specific, and this makes the diagnosis quite challenging. In terms of the disease progression, multiple sclerosis is characterized by the exacerbation of symptoms at unpredictable intervals. It is actually quite difficult to predict when those flare-ups will occur. It can be classified as early stage multiple sclerosis and secondary progressive multiple sclerosis. Early stage MS can be subdivided into two main groups. There is primary progressive MS, of which we see the minority of patients falling into, about 15% of them. And then we have the group of relapsing remitting MS. This is what most patients will exhibit. So 85% of patients with MS will fall under this category. It should be noted that those exhibiting relapsing remitting MS can then progress with time and develop neurodegeneration. At this point, it will be classified as secondary progressive MS. To help explain this point a bit better, I extracted this figure from the article by Lublin et al. From 2014, where they tried to depict the progression of those patients with relapse remitting multiple sclerosis, which is 85% of MS patients. So as we can see on this graph, we have time versus disability. When the patients first start to exhibit multiple sclerosis, they can fall under the relapse remitting group, which simply means that they will have flare-ups or relapses where they have a sudden progression of the disease characterized by a increase in disability, but they go back to their baseline level of disability. They can also then progress to what is known as active disease with progression. So what this means is that they have a relapse with new MRI activity. So we'll see clear MS plaques in the MRI. And we also see an increase in disability that never goes back to the to the baseline level of disability that they had before this relapse. Another characteristic pattern of the disease is when they have active disease without progression. What this means is that they now have a relapse, so we see a worsening in disability, but once the relapse is done and they go into a remitting phase, they go back to the baseline level of disability. However, their final level of disability is still higher than the initial baseline level. So they have progressed. The other type of pattern we can see in this disease is the not active, but progression. So in this case, we don't actually have any new changes in MRI disease progression, MRI findings of disease progression, but we do see increase in disability. The line in blue just shows periods during the disease that are known as not active and no progression. So this is a stable phase of the disease. Moving on to the diagnosis of multiple sclerosis, it is actually based on clinical criteria. So onset is usually between the ages of 10 and 50 years of age. Signs and symptoms of central nervous system white matter disease should be seen in those patients. There should be 2 or more attacks separated by a month or more. There should be involvement of 2 or more contiguous anatomic areas. Other findings that are needed for the diagnosis of multiple sclerosis include elevated levels of IgG and albumin in the CSF. In terms of imaging, we know that the MRI is a sensitive diagnostic tool in MS. It actually provides direct evidence of demyelinated plaques in the central nervous system, as we can see in the images on the right side. In terms of treatment, the main objective of treatment is to manage the symptoms. There's actually no cure for multiple sclerosis. And the objective of using immunomodulators is to try to manage the immunologic and inflammatory responses that happen in multiple sclerosis and that cause the damage of the central nervous system. Treatment is achieved by using disease-modifying drugs such as fingolimod, teriflunomide, and dimethyl fumarate. The most recent 2021 expert panel treatment guidelines presented this figure to try to help conceptualize the decision to treat multiple sclerosis. So there's basically two groups. You have patients that are asymptomatic and those that are symptomatic. So for those that do not have any symptoms, but they have radiologically isolated, a radiologically isolated syndrome, you can do watchful waiting. This means that they will not get immunotherapy, but they will have regular follow-ups with MRIs to monitor disease progression. Those patients with symptoms will be divided into three main groups. Those with demyelinating events of unknown significance, those with clinically isolated syndrome, and those with definitive relapsing remitting MS. Only those patients with clinically isolated syndrome and relapse remitting MS will be considered for immunotherapy. Everyone else will undergo watchful waiting and regular follow-ups. Patients that will receive immunotherapy can receive one of a medication from one of the three categories that we see on this table. The decision to use medication from a specific category depends on disease progression and the number of unfavorable prognostic factors. Some of the main challenges using the immunomodulating drugs is that they increase the risk of infection and malignancy in these patients. Also, they have a very significant profile of side effects, some of which include nausea, vomiting, diarrhea, bradycardia, hypertension, liver dysfunction, and peripheral neuropathy. Moving on to the anesthetic considerations, I would like to start off by saying that the effects of anesthesia on multiple sclerosis progression is not quite clear. Most of the evidence available is based on case reports and series that have suggested that general anesthetics or regional anesthesia can potentially exacerbate MS. A recent retrospective review by Delott et al. Looked at the relapse risk in the postoperative period, and they looked at the effects of invasive surgery and anesthesia. This review was performed in 2020. It looked at cases from 2000 to 2016. They had a total of 281 patients with multiple sclerosis. Out of those patients, they looked at their risk of relapse during a 90-day postoperative window. They looked at a number of surgeries. They were divided between those of minor and major surgeries. Examples of minor procedures included ortho, ablation, bronchoscopy, lithotripsy. And under the major procedures, we had bariatric, vascular, general surgery, gynecological, and urological surgeries. In terms of the anesthetic, they only looked at those patients that received a general anesthetic. They actually excluded any sedation, regional, topical, or local anesthetics. Local anesthesia, sorry. This study concluded that there was no difference. They concluded that surgery and anesthesia did not increase postoperative relapse risk. In fact, out of the 281 patients, 12 patients had postoperative relapse. And while 269 did not have one. This was statistically significant with a p-value of 0.003. They also looked at the effects of sex, smoking history, MS subtype, so progressive versus relapsing, and use of disease-modifying therapy. Out of all of those comparisons, there were no differences. In terms of aggravating factors, we know that there are several triggers in multiple sclerosis. Some of the most well-known are infection, hyperpyrexia, and emotional stress. Furthermore, we know that patients with multiple sclerosis can experience demyelination of the cervical and thoracic spine. The main consideration with this is that it can lead to intraoperative hemodynamic instability. Therefore, it is recommended that patients with multiple sclerosis undergo a very detailed and thorough preoperative assessment, especially so that we can identify those patients that could be at a higher risk of developing hemodynamic instability intraoperatively. Respiratory function can also be compromised in patients with MS. In fact, baseline respiratory muscle weakness and poor respiratory control can increase the likelihood of postoperative respiratory failure. This is mainly because of cervical demyelination that can lead to diaphragm paralysis. Therefore, it has been suggested that any patients with severe multiple sclerosis or with baseline respiratory dysfunction should undergo pulmonary function tests and blood gases preoperatively. Neuromuscular blockade used in multiple sclerosis patients should be carefully done, especially because depolarizing neuromuscular blockers such as succinylcholine can produce an exaggerated release of potassium. This is mainly due to the denervation sensitivity by upregulation of acetylcholine. Therefore, neuromuscular monitoring is strongly recommended intraoperatively. Regarding non-depolarizing neuromuscular blockers, the main consideration is that patients with MS will exhibit increased sensitivity to them. This is mainly driven by muscle wasting that is characteristic of multiple sclerosis. Also, these patients are usually use baclofen or dantrolene for spasticity. Once again, neuromuscular monitoring is strongly recommended intraoperatively, and it has been recommended that neuromuscular blockade should be titrated and properly reversed. Another major consideration in this population is temperature regulation. This is probably one of the main points that are overlooked intraoperatively. It has been shown that even a 0.5 degrees Celsius rise in core temperature can slow the signal conduction along the demyelinated segments. In fact, hyperthermia has been identified as a trigger for MS relapse. Therefore, it is essential to maintain a stable core temperature, and temperature monitoring should be used intraoperatively. Another consideration in this population is the use of steroids. Very commonly, patients that have had a recent MS relapse will receive a steroid therapy, and therefore they might need preoperative steroid supplementation to prevent adrenal suppression. It is recommended that these patients receive a careful preoperative evaluation and that are patients with recent steroid use should receive appropriate steroid supplementation intraoperatively. One of the major topics of debate is the use of neuraxial anesthesia in patients with multiple sclerosis. In fact, the controversy of using neuraxial anesthesia in this population dates back to 1949, when it was first reported the appearance of multiple sclerosis after spinal anesthesia. This led to speculation that intrathecal application of local anesthetic could precipitate the disease. And since then, there has been an ongoing concern about using epidurals or spinal anesthesia in this population. It has even been suggested that it is contraindicated. The main argument is that the use of local anesthetics along demyelinated nerves can lead to a higher risk of local anesthetic neurotoxicity. However, the precise mechanism remains unclear. So far, most of the guidelines recommend using a low concentration of local anesthetic in this population. As I tried to review some of the ASHRA guidelines, I found the ASHRA Practice Advisory on Neurologic Complications in Regional Anesthesia and Pain Medicine. The initial guidelines were published in 2008 and then revised and updated in 2015. In summary, the recommendations for performing regional anesthesia in patients with pre-existing neurological deficits are the following. So for those patients with pre-existing peripheral neuropathy, such as multiple sclerosis, it is suggested that peripheral nerve blocks could theoretically increase the risk of new or progression of the disease. However, they also point out that there's no data that can neither confirm or refute this theory. Therefore, they recommend just doing a very careful risk to benefit assessment whenever employing regional anesthesia in this population. In terms of those patients with pre-existing CNS disorders, they recommend that a careful risk to benefit assessment should be performed. And this is mainly due to the risk of increasing new or progression of neurological complications. However, once again, the evidence is still lacking, as pointed out in the guideline. When they talk about the overall approach recommended for this population, they conclude that an appropriate assessment of the patient should be performed, and we should employ the anesthetic technique that provides or minimizes the risk of disease progression. They point out that there's very minimal evidence and therefore they recommend using less potent local anesthetics, minimizing the local anesthetic dose, the volume, and or the concentration. And once again, they point out that there's limited human data that neither confirm nor refute these modifications. A recent study published in the Brazilian Journal of Anesthesiology by Borman et al. Looked at the neuraxial anesthesia in patients with multiple sclerosis. This systematic review looked at 37 articles throughout a span of 65 years out of which there were 231 patients. 10 patients with multiple sclerosis had worsening of the symptoms, but none of the cases had a clear cause and effect relationship between the use of neuraxial anesthesia and multiple sclerosis. This systematic review concluded that the current clinical evidence does not support the theory that neuraxial anesthesia negatively affects the course of multiple sclerosis. When we talk about multiple sclerosis, there's always an increasing concern with pregnancy. And this is basically due to the effects of estrogen and progesterone in disease progression. It has been shown that during pregnancy, the rate of relapse decreases significantly. As we can see on this graph, as the concentrations, the relative concentration of estrogen and progesterone increases, the risk of MS relapses actually decreases, and the symptoms significantly improve. However, this completely changes immediately postpartum. So throughout the first 3 months of postpartum, the risk of relapse is actually the highest. In terms of multiple sclerosis and pregnancy, we do know that pain and stress are well-known triggers for MS, and therefore parturents will benefit from early epidurals and CSCs. However, there's an ongoing debate about the use of local anesthetic on demyelinated nerves and neurotoxicity. And it has been suggested that this process can actually be enhanced by pregnancy. Therefore, the current recommendation is to use low-dose bupivacaine in combination with an opioid to provide an optimal epidural or neuraxial analgesia. A recent review published in the 2021 by Bouvet et al. Looked at postpartum relapse in women with multiple sclerosis after neuraxial labor analgesia and neuraxial anesthesia. This was a multicenter retrospective cohort study. It looked at a total of 118 deliveries, out of which 66 were vaginal deliveries and 66% were vaginal deliveries and 34% were C-sections. In terms of the interventions, 50 neuraxial analgesia, 46 had neuraxial anesthesia, and 22 had no neuraxial intervention. They found postpartum relapse in 31, so 26% of deliveries. There was no statistically significant association between obstetric or anesthetic characteristics and relapse. However, they did find that the occurrence of relapse within the within the year preceding the pregnancy was the only independent factor that was associated with postpartum relapse. This brings me to the conclusion of this presentation. I have attached all of my references, and I thank you very much for being part of this presentation. Thank you.